respiratory pathology, epistaxis, DVT, and PE. So the first thing we're going to be talking about for respiratory pathology is epistaxis, and all that is just bloody nose. And what we need to know is that epistaxis is caused by irritation of the Kisselbach's plexus, and that's located at the anterior nasal septum. All right, so just know that location of the Kisselbach plexus and know that that is what's irritated when we have epistaxis, okay? And it's very common in adolescent males. Next is the DVT. So we already discussed the deep vein thrombosis, but all it is just a blood clot that forms within our vein, the deep veins of our legs. And there's a Respiratory triad which predisposes us to the DVTs, and that is number one, stasis. So if you have like a long drive or a long flight, that's the first thing that predisposes you. Number two is hypercoagulability, which is a defect in coagulation cascade proteins, like specifically factor V Leiden is one of a very common cause of the hypercoagulable state and hence a DVT. And then lastly is the endothelial damage. Endothelial damage is the third portion of the Virchow's triad, which leads to a DVT. Now, one of the main concerns for our DVTs, our deep vein thrombosis, is if they get dislodged. And once they get dislodged, they can travel all the way to the right side of the heart, and the right side of the heart is going to pump it into the lungs and cause a pulmonary embolism. Okay? And the PE is a major complication because if we have a pulmonary embolism, it leads to a VQ mismatch, which ultimately can cause death in a patient because we don't have proper perfusion to an area within the lungs. So for the first thing that we need to know about PEs is that the affected alveoli are ventilated, but they're not perfused. And that makes sense because when we block the blood flow to a certain area, we're not specifically changing anything when it comes to ventilation, right? We're still able to breathe in and out normally, but we can't get new blood into that area for it to be oxygenated, okay? And so then that will lead to sudden onset dyspnea, pleuritic chest pain, tachypnea, tachycardia, hypoxemia, and respiratory alkalosis, okay? Now, the common presentation is going to be a patient that's post-op. Okay, so once you have a patient that's post-operation in the hospital, just kind of getting better after an operation, they have little movement. So it increases the risk for that Virchow triad, right? Because stasis is one of the three portions of the Virchow triad. So since they have decreased movement, it increases the risk for having a DVT and ultimately PE. And that's a very common presentation. Keep that in the back of your mind. If a vignette is talking about a patient that just had surgery and they've been in the hospital for a little bit, start thinking about a pulmonary embolism, especially when they're talking about a patient having chest pain, tachypnea, so they're starting to breathe really quickly, and it leads to respiratory alkalosis, right? Because they start to hyperventilate and blow off their carbon dioxide, leading to a alkalotic state, specifically respiratory alkalosis. Okay? Now, these can lead to sudden death when the emboli is placed between kind of the breakage point between the two pulmonary arteries. So keep that in mind. I mean, it's not very high yield, but that's just something that they like to ask about. And it causes an increase in physiological dead space. That makes sense because physiological dead space is just the amount of space where gas exchange cannot occur. Now, we have anatomical dead space usually equal to physiological dead space, but if we have a PE, we block the ability to perfuse new blood, right, to ventilate new blood due to the fact that we decrease perfusion. And so an overall increase in physiological dead space will be seen, okay? Now, there's different types of emboli that can form and go and create a pulmonary embolism besides blood. So we already talked about how a DVT, which is from blood clotting, can dislodge and form a pulmonary embolism, but we could also have a fat emboli. And there's a triad seen with fat emboli that you need to know, okay? So what happens is if a patient breaks their leg, like a long bone fracture or liposuction, you can get fat essentially within the bloodstream, okay? And the classic triad that you're gonna see is hypoxemia, neurological abnormalities, and a petechial rash, okay? And the petechial rash is gonna be a huge, huge hint. So if a patient comes in after maybe a car accident, they said that they have major bone breakage, and then they have petechial rash noted on their abdomen maybe, and then they have neurological abnormalities with hypoxemia, start thinking about fat emboli because this triad is very important for fat emboli. Air emboli, not as important. I don't even think I got tested on it, but it's just for ascending divers. So if you are a diver and you ascend too quickly, then you're going to have like essentially nitric oxide gas, like an air emboli inside your blood. All right. That's all for our epistaxis, DVT, and pulmonary embolism. These are relatively higher yield concepts, but just understand kind of the pathophysiology behind it. They love to ask about specifically factor V Leiden's pathology associated with DVTs and PEs, so keep that in the back of your mind, as well as a VQ mismatch for pulmonary embolism. But that's pretty much it, and we'll be moving on to the next portion, which is obstructive and restrictive lung diseases next.